Welcome back, everyone. We're now going to move on and we're going to talk about the term mastication, be able to define what it means and identify the structures involved in this process, describe the structure and function of the salivary glands, define the term deglutition and identify the structures involved in deglutition, list and summarize the features of the stomach, describe the histology and functions of the stomach and its secretions, and finally, describe the movements in the stomach. Now, starting with the oral cavity, it's bounded by the lips, the superior and inferior lips anteriorly, and also by the fauces, which are those openings into the pharynx or the throat posteriorly. The oral cavity can be divided into two regions. Firstly, we have the vestibule, which you can see here, and that's that space between the lips and the cheeks and the alveolar processes containing the teeth. And then, of course, we have the oral cavity proper, which is medial to the alveolar processes, and it's lined with moist stratified squamous epithelium to protect against abrasion. The lips and the cheeks then are both muscular structures that are important in mastication or chewing, and also speech production. The lips or the labia are formed by the orbicularis oris muscle, and they also have keratinized stratified squamous epithelium, which is thin, particularly at the margins, and then the color of blood flowing in the dermis, but in blood vessels in the dermis below, gives the lips a kind of a pinkish color to a dark red color. The labial frenula, so one or more labial frenula, which are these mucosal folds, and you can see the inferior one here, extend from the alveolar processes of the maxilla and the mandible to the upper and lower lips respectively, and many facial muscles act to move the lips. The cheeks form the lateral walls of the oral cavity, and they contain this buccinator muscle which flattens the cheek against the teeth. There's also a buccal fat pad, and that kind of gives that sort of rounded profile on the side of the face. So the lips and the cheeks then, help to move food in the mouth while, your teeth grind that food. And they also help to form words, as you can see me doing right now. Moving on then to the palate and the palatine tonsils. The palate itself has two components. Anteriorly, we have this bony, hard palate, which is supported by the maxilla and the palatine bone. And then posteriorly, we have a non-bony palate called the soft palate. And it consists of skeletal muscle and connective tissue. And you can see here the uvula or the grape, which projects there from, the posterior of the soft palate. And the palate itself is really important because, in swallowing, because it prevents food from entering the nasal cavity during that process. We also have the palatine tonsils that we talked before in the lymphatics and immune topic, and they form the lateral walls of those fauces, which are the openings to the pharynx, and they're really important in immune function and that first line defense against any kind of pathogens entering the mouth. Now, the tongue itself is a muscular structure. It has a free anterior surface and attached posterior surface, and it's covered with moist stratified squamous epithelium, again, to protect against abrasion. I mentioned that it's a muscular structure, so it has these intrinsic muscles that can change the shape of the tongue. You might want to be doing it while I'm talking here. And also extrinsic muscles that protrude or retract the tongue and move it from side to side. If I just go back a slide now in a second, the lingual frenulum attaches the tongue inferiorly to the floor of the oral cavity. So that's what you're looking at there. And a person is said to be tongue-tied if this lingual frenulum sort of extends too far towards the tip of the tongue, and that then interferes with, tongue movement and speech production. So a little surgery can be done to correct that. Okay, if we go back here to the tongue, it contains this terminal sulcus, which you're looking at here, which is a groove that divides the tongue into the anterior part, which is 2/3 of all of the tongue, and the posterior part then, which is 1/3. The anterior part contains all of these papilla, some of which have taste buds, and those taste buds, allowing us to, have that sensation of taste. And we'll do something in the tutorial about, your ability to taste different things, and it's quite a lot of fun. The posterior part, then, there's no papilla and a few scattered taste buds. It does contain a lymphoid tissue embedded in the posterior surface, and this lymphoid tissue is called the lingual tonsil, again involved in defense. And the tongue itself moves food in the mouth, it participates in speech, and it also participates in swallowing. All right, so we'll move on to the teeth. And for everybody enrolled in dental science or oral health science, this is not, supposed to be your education on the teeth. You will do a lot on that, as you have already in your DOH subjects. 2 sets of teeth, though, everybody. Firstly, we have primary or deciduous or milk teeth. These are the ones present in childhood. These are the ones then that are replaced with these adult teeth. Usually at about 6 to 8 months old, when the baby, starts getting these red cheeks and starts crying, you know that there's going to be a little central incisor there about to sort of erupt through the gum line. Okay, so these primary or deciduous milk teeth are replaced with these permanent or secondary teeth. And adults, normally have 32 teeth, and they're distributed in these 2 dental arches. One is the maxillary arch and the other is the mandibular arch. Now, the teeth on the right and left halves of each dental arch pretty much or roughly sort of mirror images of each other. And so that divides all our teeth then into 4 quadrants. So we have right and left upper and right and left lower. So within a quadrant then, there is one central incisor, one lateral incisor, then we have one canine, then we have the first and the second premolars, and then the first and the second or third molar there, which is also called the wisdom tooth, because, they usually sort of appear late in teens when people have supposedly acquired some wisdom. So very briefly then, in terms of function, the incisors and canines are involved in biting or cutting, into food, whereas the molar type teeth then are, more involved in the grinding of food. So the teeth are involved in mastication and speech production. Just very briefly, everybody, in terms of, the different sort of anatomy of the tooth, we have the anatomic crown. This is the enamel covered part of the tooth. The clinical crown then is the section of the tooth above the gum line, and the neck then is the enameled part of the tooth below the gum line. Enamel itself, as you can see there, is it covers the outermost layer of the anatomical crown. It's a non-living substances, so we say that it's acellular, and it protects the tooth. The root then is embedded within the maxilla and the mandible. Dentin is the living cellular calcified tissue. In the root, dentin is covered by cellular bone-like structure that helps hold the tooth in the socket. We also have this pulp cavity, as you can see here. It's filled with blood vessels and nerves and connective tissue. And we also have this ligament here called the periodontal ligament that holds the tooth in the socket. The gingiva up here, more commonly sort of known as the gums, are dense fibrous connective tissue covered by stratified squamous epithelium. Dental caries or tooth decay is caused by the breakdown of enamel by acids produced by bacteria on the surface of teeth. Mastication then is a word for chewing, and it involves the incisors and the canines that bite or cut off food, and as I mentioned before, those molar type teeth that grind or gnash the food. Now, there are 4 pairs of muscles that are involved in sort of manipulating the mandible, and they are the masseter, the temporalis, and the medial and lateral pterygoids. The ones that sort of close the jaw or elevate the mandible to close the jaw are the temporalis, the masseter, and the medial pterygoids. And those that open the jaw then or depress the mandible are the lateral pterygoids. Protraction and lateral and medial excursion of the jaw is due to the pterygoids and the masseter, and then retraction is, the role of the temporalis muscle. The mastication or chewing reflex then is initiated in the medulla oblongata, and it controls, the basic movements that are involved in chewing. However, there are descending pathways from the cerebrum which provide us with that, conscious control of chewing. Okay, so we are going to talk about the salivary glands in this part of the topic because they are associated, with the oral cavity. And they produce saliva, believe it or not. There are 3 pairs of multicellular glands. The parotid here is the largest. And they produce, a serous or watery secretion. They're located just anterior to the ear, and the parotid duct itself then, crosses over the masseter and it penetrates the buccinator and it enters the oral cavity adjacent to the second upper molar. Then we have the submandibular salivary gland there, which kind of secretes a mixed secretion, which is more watery than mucus. These are located on the posterior half of the inferior border of the mandible, and the duct enters the oral cavity on either side of that lingual frenulum. And then we have the sublingual salivary gland, which is the smallest, and it secretes a mixed secretion as well, but it's mostly mucus in this case. And each of the sublingual salivary glands have 10 to 12 ducts that enter the floor of the oral cavity. We also have lingual glands, which are small coiled tubular glands that are located on the surface of the tongue. So if we just look at the composition of saliva, it's nearly all water, right? The remaining 4 to 5% though is a mixture of ions, glycoproteins, enzymes, growth factors and waste products. It does contain the enzyme salivary amylase, which begins the digestion of starch. So it catabolizes starch into the disaccharides maltose and isomaltose. Food doesn't tend to hang around in the mouth for very long though, so you don't get too much carbohydrate digestion occurring. And then, that salivary amylase does continue acting until it's inactivated by hydrochloric acid in the stomach. The bicarbonate and phosphate ions then will sort of function as chemical buffers, maintaining saliva at a pH between 6.35 and 6.85. We do have this mucus that's present in saliva, and it acts to lubricate food, and that facilitates the movement in the mouth and that bolus formation that I was talking about earlier. And therefore, once that bolus is formed, it facilitates swallowing to occur. Saliva also contains secretory IgA, which is immunoglobulin A, which prevents bacterial infection, and it also contains lysozyme, which has an antimicrobial effect. And parasympathetic nervous system signals cause saliva production. So even, the sight of food or the thought of food increase saliva production. So as I'm speaking, you might be thinking about food. You might actually feel, that saliva getting going. In terms of other sort of digestive enzymes, we do have lingual lipase, which is from the lingual glands, and they act on fat, so on triglycerides, to produce free fatty acids and mono and diglycerides. The pharynx then, or the throat, is involved in both digestion and respiration. We've talked about this one before. It receives food and air from the mouth and air from the nasal cavities. It's a short tube of skeletal muscle and it's lined with a mucous membrane. The pharynx runs from the posterior oral and nasal cavities to the opening of the esophagus and, of course, the larynx. It has three subdivisions: the nasopharynx, which is involved in breathing and speech. And the other two subdivisions then, the oropharynx and the laryngopharynx, breathing and digestion. And the wall of the oropharynx itself is lined with moist stratified squamous epithelium with mucus-producing glands. The mucus provides the lubrication and the stratified squamous epithelium is there for protection against abrasion. That's all we're going to say for this slide. I'm going to move on now to the process of swallowing, which is also known as deglutition. It involves the pharynx and the esophagus. The posterior walls of the oropharynx and laryngopharynx contain groups of muscles called pharyngeal constrictors that contribute to swallowing. The esophagus itself is this sort of straight tube that's about 25 centimeters long, and it transports food from the pharynx to the stomach. The esophagus itself passes through the diaphragm, through this esophageal hiatus, which is this opening, and it ends at the stomach. And a hiatal hernia, which does occur to some people, is due to this widening of this hiatus. Okay, and when you do have a hiatal hernia, that can allow then for gastric reflux to occur. There are two esophageal sphincters, so they are the upper esophageal sphincter and the lower esophageal sphincter. The upper contains skeletal muscle. It's striated, it's under conscious control, and when it relaxes, the bolus of food enters the esophagus. The lower one then, the lower esophageal sphincter, contains smooth muscle, so it's under involuntary control. And when it relaxes, then food enters the stomach. So that bolus of food enters the stomach. And rhythmic and powerful peristaltic waves move food, through the esophagus and on into the stomach. So swallowing does occur in 3 phases. It's not important for you to go into the details of this too much, but there's a voluntary phase, right? The bolus of food is moved by the tongue from the oral cavity to the pharynx. The pharyngeal phase then is due to a reflex. It's controlled by the swallowing center in the medulla oblongata. The soft palate elevates, the upper esophageal sphincter relaxes, and the elevated pharynx then opens the esophagus, and food gets pushed into the esophagus by these, pharyngeal constrictors, successively sort of contracting from superior to inferior. The epiglottis is tipped posteriorly due to pressure of the bolus of food, and the larynx is elevated then to prevent food from passing into the larynx and then on into the other parts of the respiratory tract. The esophageal phase then is a reflex as well, and stretching of the esophagus causes that enteric nervous system to initiate peristalsis of muscles in the esophagus. So just to summarize the esophagus, it does contain stratified squamous epithelium in the mucosal layer, and that protects against erosion from food particles passing through. The upper esophageal relaxes to allow the bolus to move from the laryngopharynx into the esophagus. We have those really powerful waves of peristalsis propelling the bolus through the esophagus and onto the stomach. We have lower esophageal sphincter relaxation, which allows the bolus to move from the esophagus into the stomach, and then when it contracts, it prevents that chyme from, going back up into the esophagus. And mucus secretion all along the length of the esophagus lubricates it, allowing easy passage of the bolus. Okay, I was going to include the stomach in this recording, but it's just gone on a bit too long. So I'm going to let you digest, excuse the pun, and the information that I've been talking about. And when I come back, I'll do the stomach, the small intestine, and the large intestine.